Welcome to the session on Pleural Disease Update for 2018. I'm Scott Chassell from Pulmonary and Critical Care Medicine at Brigham Women's Hospital. And I have no disclosures, and I want to acknowledge one of our junior faculty, Dr. Catherine Walker, for her contributions to some of this case. Our outline today for pleural disease will be a bit more advanced and cover a case-based array of topics and highlight some of the new evidence-based management of several pleural diseases, including empyema, hemothorax, chylous effusions, thoracic endometriosis syndrome, hepatic hydrothorax, and more, and hopefully we'll hit on some highlights along the way. Starting right in with our first case addressing empyema is a 72-year-old man with 3 days of cough, sputum, fever, and dyspnea. Exam reveals a fever and decreased right basilar breath sounds. Laboratory demonstrates a leukocytosis, and his chest x-ray shown here shows a moderate-sized right-sided effusion, which on lateral decubitus films is free-flowing. Blood cultures were obtained and antibiotics started. If we think about the pathogens causing community-acquired infected pleural effusions, or empyema, most clinicians will appropriately steer towards pathogens that cause pneumonia, such as pneumococcus and Haemophilus influenza. But note that intermediate strep, or strep milleri, account for more than a third of all community-acquired empyemas, indicating the microbiology of empyema, even in the absence of pneumonia, is a bit different for community-acquired pleural space infections. When examining hospital-acquired pleural space infections, the pathogens are a bit more predictable, such as MRSA or Staph aureus species, gram-negative rods, such as Enterobacter species. Strep milleri is present but diminished, and Enterococcus and H. flu are still present. With regards to updates, diagnosis is best if we have positive cultures to guide treatment. We all appreciate, however, that pleural fluid cultures are positive in only about 1/3 of empyema cases. In this 2011 study, more than 60 patients had empyema and were compared to either standard pleural fluid cultures or cultures from blood culture bottles inoculated with either 2, 5, or 10 cc's of pleural fluid immediately at the bedside. And blood culture bottle inoculation increased the pathogen yield from approximately 1/3 to nearly 60% of patients. And 2 cc's of pleural fluid was equivalent to 10 cc's of fluid. The conclusion here is that we should consider blood culture bottle inoculation of pleural fluid when empyema is suspected, and the ability is present at the bedside for this type of culture collection. Back to our case, thoracentesis on this gentleman was performed, and the fluid was serosanguinous with a pleural fluid protein of 3, serum of 4, LDH elevated at 800, serum of 300, and a pH of 7.18. Gram staining cultures remained negative. So our first question is, next step in managing this effusion is antibiotics and close observation, including daily chest x-rays, thoracentesis to drain the pleural space, VATS decortication, chest tube drainage with or without fibrinolytics to the pleural space, or E, A, or D. And our answer is D, chest tube drainage with or without fibrinolytics to the pleural space. Why do we want to drain this gentleman's chest, and what are the complications of parapneumonic effusions that are mitigated by drainage? Undrained complex pleural effusions such as this can lead to chronic pleural infection, formation of secondary lung abscess, and a creation of even a bronchopleural fistula, where the pleural space communicates with the lung parenchyma through erosion and necrosis, and then out through the chest wall itself, forming a pleurocutaneous fistula. In short, one could have a bronchopleurocutaneous fistulous tract over time with untreated pleural space infection, which is a very challenging infectious and surgical case to handle. There are mechanical complications, even if the space is eventually sterilized, such as pleural fibrosis, leading to lung entrapment, impaired lung function, and possibly requiring thoracotomy and surgical decortication. So how do we know who to drain? And this table outlines elements of the clinical imaging and pleural fluid characteristics that define high or low risk of one of these dreaded outcomes for empyema. So if on lateral chest x-ray you have a very small effusion, less than 10 millimeters, you wouldn't even tap this patient, but you'd follow the patient closely, and the risk of a poor outcome is low. If on imaging you have an effusion that's larger, half the hemithorax, and it's tapped and sampled, and the gram stain and cultures are negative, and the pH is greater than 7.20, the risk of one of these poor outcomes is low, but this effusion needs to be followed for development of concerning clinical signs such as fever, increased pleuritic chest pain, or evidence of ongoing infection. If the effusion is large, more than half the hemithorax, loculated, or has pleural thickening, these are anatomic criteria for drainage due to high risk of poor outcome. Or if the fluid culture or gram stain are positive regardless of fluid size, or the pH is less than 7.20, the presence of any one of these parameters indicates high risk for poor outcome, and drainage, complete drainage and persistent drainage of that pleural space is mandatory. With regards to drainage and treatment, we commonly employ a large bore, surgically placed closed thoracostomy chest tube, although the other extreme, such as serial thoracenteses, is theoretically achievable but not well studied and not currently recommended. Our interventions have now landed somewhere in the middle, and placement of a small bore pigtail pleural catheter with or without fibrinolytic therapy is evolving to be an acceptable mode of treatment. If we look at the evidence behind this intervention, the early trials, the first MIST trial, randomized patients with empyema to pleural saline versus streptokinase, and streptokinase installation into the chest did not improve survival, need for surgical intervention, chest CT appearance, or lung function. Not until 2011, when the second MIST trial was performed and a different fibrinolytic strategy was employed, did we start seeing benefit from this mode of empyema treatment. And in this trial, pleural saline was administered to the pleural space versus TPA, or tissue plasminogen activator, or fibrinolytic, or DNase versus both medications, TPA and DNase, for a total of 3 days. And then patients were observed. And the fibrinolytic, or TPA and DNase group, had a decreased need for surgical intervention at 4% compared to 39% for the pleural saline and placebo group. And they had markedly improved radiographic improvement of their pleural disease at 1 week versus 30 days. Here's just one representative example. We see this volumetric diagram around this pleural effusion at day 0, and by day 7, a marked improved resolved infected empyema and pleural effusion after TPA and DNase. However, there are considerations when making a decision to use intrapleural TPA. There's an appreciable risk of pleural hemorrhage, some of it quite severe, requiring resuscitation and blood product replacement. And that risk is now approximately 1.8, let's just say 2%. So if a patient is at risk for hemorrhage for other independent comorbidities, this must be considered. In addition, the installation of these enzymes markedly stimulates pleural fluid production, up to 6-fold output of fluid, usually immediately after installation. This is part of the presumed therapeutic benefit, as the rapid fluid accumulation fills the space, presumably breaks fibrinous loculations and promotes drainage. But this can cause pain and an inflammatory reaction in the pleural space. And if the patient already has a bronchopleural fistula, evidence of a hydropneumothorax on presentation, installation of fibrinolytics is a relative, if not significant, contraindication, as we do not want to perpetuate the presence of a bronchopleural fistula. If patients fail either bedside closed thoracostomy chest tube placement or pigtail and fibrinolytic drainage of the chest, surgical decortication may be needed, and this is only in approximately 30% of cases. Fortunately, 2/3 or more of cases requiring surgical decortication can be done through thoracoscopic incisions and not a mini or full thoracotomy. Antibiotic therapy is guided by the microbiology, either empiric or defined by cultures, and should be continued past the point of complete cessation of pleural fluid drainage. Generally, this is a minimum of 2 weeks, but can be prolonged depending on the extent of pleural fluid drainage, or pathogens such as actinomyces may require months of antibiotic therapy. Changing topics to a spontaneous hemothorax. This was a case of a 37-year-old woman with 2 months of dry cough and dyspnea on exertion and right anterior chest pain. Her past medical history is as listed here. Her chest x-ray shows a right-sided pleural effusion, moderate in size, and what's not appreciated entirely on this x-ray is she also has a pneumothorax with an apical pleural line up here. Thoracentesis was performed, and she had a high LDH, normal pH, normal glucose, and a mixed pleocytic white blood cell population, but the fluid was frankly bloody, and hematocrit of the fluid was a concerning 22%. So when we look at pleural fluid hematocrit, we have different thresholds for being concerned for non-bloody, non-hemorrhagic, right through to frank hemothorax and bleeding. And if the fluid hematocrit appears blood-tinged and the hematocrit is less than 1%, that's not a significant amount of blood. If the fluid hematocrit is 1 to 20%, that is a hemorrhagic process, but not necessarily frank vascular bleeding, and we are concerned about malignancy, pulmonary embolism or PE, trauma with limited hemorrhage or empyema with hemorrhagic inflammation from infection. If the hematocrit is between 20 and 50%, that of the circulating hematocrit, that indicates one of the above hemorrhagic processes with more substantial hemorrhage, or there could be frank hemothorax, even with a pleural fluid hematocrit less than 50% of the circulating hematocrit, since that cutoff of 50% is a bit arbitrary, and a fluid hematocrit of 30% is still quite concerning for frank hemorrhage. When the pleural fluid hematocrit is greater than 50% of the circulating hematocrit, that is a frank hemothorax and hemorrhage. Our diagnostic algorithm for approaching bloody effusions is guided a bit by the clinical history and by the pleural fluid hematocrit. So if there's no evidence of trauma or procedures, and the pleural fluid hematocrit is less than 50% of the peripheral blood hematocrit, common etiologies of hemorrhagic processes, as reviewed before, include lung cancer, pulmonary embolism with infarction, hemorrhagic atypical infections such as tuberculosis, hemorrhagic empyema, uremic pleuritis, coagulopathy, or cancers like mesothelioma. If the pleural fluid hematocrit is greater than 50%, indicating frank hemothorax, additional studies of the vasculature should be obtained, such as CT angiogram or MRA, and if vascular anomalies are present, such as an AVM, an aneurysm of one of the intercostal arteries or internal mammary arteries, then those etiologies will be identified. Non-vascular hemothorax would suggest processes such as endometriosis, hemorrhagic metastases to the pleural space, highly vascular tumors such as angiosarcoma, thymoma, thymic cysts. And in cases where there is simply no etiology found, we often see very bony protrusions along the vertebrae called exostoses. And in generally older patients who have vessel fragility, who may be on antiplatelet or anticoagulation therapy, this would be a plausible diagnosis of exclusion, but a diagnosis of exclusion, and usually is a self-limited hemorrhagic process. This patient with a hydropneumothorax and hemothorax underwent right video-assisted thoracoscopic surgery and exploration and had a wedge biopsy of her lung and biopsy of pleural implants. These pleural implants are actually endometrial tissue, and we actually see endometrial tissue scattered throughout this lung biopsy specimen, indicating that this is thoracic endometriosis as a cause of her hemothorax and pneumothorax. Just a brief review of manifestations of TES. It's relatively rare, affecting approximately 5 to 7% of patients with endometriosis. The most common manifestation is still catamenial pneumothorax, accounting for about 80 to 90% of TES cases. That makes us wonder how many spontaneous pneumothoraces in women of reproductive age are actually due to unrecognized TES. And several case series have attempted to highly and aggressively characterize patients and come to this conclusion. The more recent one in 2003 suggested that up to 1/5 of women with pneumothorax spontaneously without alternative explanation may be due to undiagnosed TES. Major manifestations, as we reviewed, include pneumothorax, hemothorax or hemopneumothorax, as in our case, that's only 14%. Hemoptysis, lung nodules, and other rare manifestations include isolated catamenial pleuritic chest pain, catamenial pneumomediastinum, pulmonary vascular invasion, or pleural-based masses. And what's important to realize is that pelvic endometriosis may not be present in up to 1/3 of patients with TES. The goals of therapy are to prevent pleural or parenchymal implants of endometrial tissue from cycling and causing bleeding or symptoms in the lung, and that could be achieved with oral contraceptives, the first-line agent, up to chemical castration with GnRH analogs. Medical therapy alone often leads to recurrent thoracic endometrial disease when it's complex and must be paired with surgery. The goals of surgical therapy are to complement the medical therapy, and this could include simple chest tube decompression, pleuroscopy for hemo or hemopneumothorax, VATS resection of pleuroparenchymal nodules, repair of any diaphragmatic defects. And if we look at patients treated with just medical therapy alone, catamenial pneumothorax can recur in up to 60% of patients on hormonal therapy at 1 year versus only 1/5 or less of patients who get both surgical management of pleural disease and medical therapy. So combined modal approach of treatment is important. Moving on to a bit of a surprise case, and we'll cover this topic in detail. It's a 53-year-old man with 2 months of acute on chronic dyspnea. He has 3+ ankle edema, orthopnea, and paroxysmal nocturnal dyspnea worse than his baseline. And he, in fact, has heart failure with preserved ejection fraction, atrial fibrillation, and hypertension. This presentation seemed to be one of congestive heart failure. In fact, his chest X-ray demonstrated a unilateral moderate to large pleural effusion, but without significant evidence of interstitial edema. A thoracentesis was performed, and the surprise is here. We had 1,200 cc's of a lymphocyte-predominant exudate, but with triglycerides of over 1,000 and clear lipemic fluid that was drained from the chest. So how do we know whether this is a chylothorax or not? In cases where you suspect chylothorax, such as this, you measure at first the pleural fluid triglyceride. And if the pleural fluid triglycerides are greater than 110, then that is indicative of, in fact, a chylothorax. If the triglycerides are less than 50, that's likely a pseudochylothorax, which I will talk about in a moment. And if the triglycerides are between 50 to 110, that's indeterminate, and we need a chylomicron analysis, which can sometimes take several days since it's a lipoprotein assay. And if chylomicrons are present in any of these circumstances, it is by definition a chylothorax, since they should not be present in the pleural space. Etiologies of chylothorax are broken into traumatic and non-traumatic. Traumatic include chest trauma or thoracic surgery. Non-traumatic or medical causes include invasive processes or obstructive processes of the thoracic duct, such as lymphoma, solid tumors, chest radiation, and fibrosis. Chronic mediastinal fibrosing mediastinitis from histoplasmosis, TB, or sarcoid. The presence of chylous ascites, as is often seen in end-stage liver disease, with some transudation across the diaphragm and creating a chylous effusion. Lymphangioliomatosis, or LAM, a known lymphatic disorder called yellow nail syndrome. Amyloidosis, even chronic left subclavian vein obstruction such as DVT can lead to increased pressure in the thoracic duct and leak, and obstructive processes of the lymphatic system such as filariasis. Often, pleural fluid could be cloudy and even lipemic, but the triglycerides are quite low. And in those cases, this almost always represents not triglyceride-rich fatty fluid, but cholesterol and phospholipid complex. And remember that lipoproteins are relatively cholesterol and phospholipid poor, but cell membranes are cholesterol and phospholipid rich. So these effusions are called pseudochylothorax because they are not chylomicron containing thoracic duct in etiology. These represent chronic effusions usually with cell degradation and cell membrane collection. And you can identify these by a high cholesterol and low triglyceride level versus a true chylothorax, which has a high triglyceride level and a low cholesterol content. Recall that the thoracic duct bifurcates. So here's the cisterna chyli in the abdomen, and in the thorax, we have two branches of thoracic duct. So a chylous effusion can be present in either hemithorax. And chyle loss is a serious problem associated with morbidity and mortality because of the following mechanisms. Chylous fluid is fat-rich, and so one can become depleted in both lipids and fat-soluble vitamins. You lose proteins and immunoglobulins and lymphocytes, leading to malnutrition and immune suppression, and an associated mortality of untreated, uncontrolled chylous effusion of nearly 35%. Management of a chylous effusion is really predicated on a multimodal approach and dictated a bit by the cause of the chylous effusion. We often try to decrease chyle flow, and that can be achieved by giving no short or long chain triglycerides and only giving medium chain triglycerides, a diet that's very hard to follow, or augmenting with octreotide or somatostatin to decrease splanchnic flow. And maintaining nutrition through medium chain triglycerides as above, often through TPN. Removing chyle, such as through thoracentesis, thoracostomy, or pleuroperitoneal shunt, can be employed, but is challenging. And closing the chyle leak is most effective in patients with an acute traumatic thoracic duct rupture and less so with medical disease, and this could include pleurodesis, embolization, or duct ligation. Surgical interventions that I just listed are outlined here and are best if performed early and in patients who have had surgical or thoracic trauma accounting for the thoracic duct disruption. And that includes ligation, pleurectomy, pleurodesis, pleuroperitoneal shunt, which you cannot do in chylous ascites, pleurovenous shunt, which is technically difficult, and complications are abound with these approaches. This being said, if you look at outcomes of patients who have traumatic, importantly traumatic chylothorax, diet change alone leads to about a 50% success rate, so that's first-line therapy, and patients who failed diet either had pleurodesis or attempts at surgical ligation, and 100% success was ultimately achieved, indicating that although the morbidity and mortality of surgical intervention for chylothorax is high, the success is also high when thoracic duct injury and chylothorax was due to original trauma, not true with medical causes. Medical therapy for chylothorax can include decreasing of splanchnic blood flow by octreotide or somatostatin, midodrine and alpha-1 adrenergic agonist, or orlistat to inhibit triglyceride absorption. Non-surgical or semi-invasive approaches to disrupt the thoracic duct include interventional radiology-based lymphangiogram and embolization. And in this patient, we see a lymphangiogram of a normal thoracic duct here emptying up towards the thoracic outlet and subclavian. And in our patient, he had just no discernible thoracic duct, and in the end probably suffered an idiopathic lymphatic atretic disorder, accounting for his edema and chylothorax, and he was managed with an attempt at pleurodesis and dietary change. Changing gears slightly to management of malignant pleural effusions. So this is a 73-year-old man with stage 3B non-small cell lung cancer who has 3 weeks of progressive shortness of breath, and chest X-ray reveals a large new right pleural effusion as demonstrated here. A large volume thoracentesis is performed, removing almost 2 liters of serous sanguineous fluid. Pleural fluid analysis reveals malignancy consistent with his non-small cell lung cancer. The patient reports a marked improvement in his dyspnea after the thoracentesis. So what is the therapeutic approach to malignant effusions? If symptoms are not present, by definition, this is stage 4 disease, and alternative systemic therapies for the patient should be pursued, but the pleural effusion should not necessarily be mechanically intervened upon since there's no symptoms. If symptoms are present, and a large volume of thoracentesis should be performed, and if there's no improvement in symptoms, one must consider alternative therapies for malignancy, alternative causes of their symptoms of dyspnea, or frank palliative treatment in these cases. If symptoms are dramatically improved, as in our case, and the fluid accumulates very slowly, then interval serial thoracenteses are reasonable until disease control is obtained through chemotherapeutic modalities or the fluid starts accumulating more rapidly. And when that happens, indwelling pleural catheters are preferred, certainly preferred in a debilitated or lung entrapment case. But if the patient's extremely high functioning and there's no lung entrapment, chest tube places and pleurodesis is not unreasonable. And much has been published over the last decade comparing these two modalities of treatment. For example, in 2012, in the Journal of the American Medical Association, a study was performed on over 100 patients with malignant pleural effusion to indwelling pleural catheter or IC versus talc-based pleurodesis as first intervention. The catheter group had improved dyspnea at 6 months, even greater than the pleurodesis group, and no initial hospital days versus 4 days on average for the pleurodesis patients. But more complications were associated with the indwelling pleural catheter, including local site infections and, importantly, clogged catheters requiring further intervention. As demonstrated in this table, for indwelling pleural catheter, there were 7 infections and only 1 in the talc group, and catheter obstruction, obviously, in only 1 of the talc group, but in 10 of the indwelling pleural catheter group. One question that has come to attention for patients with a malignant pleural effusion and an indwelling pleural catheter is the rate of pleural fluid drainage. Traditionally, the drainage was limited to prevent fluid and protein loss. However, we all have realized over the last several years that manipulation of the pleural space and drainage may promote spontaneous pleurodesis and shorten the required time of having a pleural catheter in place. So this 2017 manuscript looked at 149 patients with an indwelling pleural catheter, randomized to a 1 liter daily versus every other day or less drainage schedule. And the daily drainage group had much faster pleurodesis, 50 days versus 90 days, and a higher pleurodesis rate at 85 days of 62% versus 42%, as shown on this graph of probability of pleurodesis for daily drainage versus every other day. So if indwelling pleural catheter is placed, the goal is to have a marked decrease in pleural fluid accumulation and the catheter removed. So pursuing a more aggressive daily drainage management approach is likely better if there are no contraindications. Finally, if we summarize the role of an indwelling catheter and sort of risks or costs and benefits versus pleurodesis, we see that indwelling catheter is much less invasive, pleurodesis is clearly more. The acute pain and acute hospitalization is clearly higher with pleurodesis. And the benefits of dyspnea control are essentially equivocal between indwelling pleural catheter and pleurodesis and may be achieved faster with indwelling pleural catheter. And the effusion recurrence rates is actually smaller with indwelling catheter versus pleurodesis. And as we just pointed out, and perhaps even more expeditiously, autopleurodesis can be achieved with daily drainage at surprisingly high rates compared to the gold standard, which is a formal pleurodesis and talc pleurodesis maneuver. Excuse me. So in summary, indwelling pleural catheters are generally standard of care for management of malignant effusions, and pleurodesis is reserved for patients who do not want a catheter and who are very high functioning. Here's an additional case to introduce a new topic. This is a 55-year-old man with subacute dyspnea. He has a history of alcohol use and is presenting with a tense right hydrothorax. His exam revealed decreased breath sounds on the right chest and ascites in his abdomen. We see in his radiograph here complete opacification with shift of both the trachea and the cardiac silhouette to the left, indicating tension in that right hemithorax. And pleural fluid analysis revealed a very low protein, a low LDH. And so the question is, what is the etiology of this right-sided pleural effusion? And not surprisingly, it is a hepatic hydrothorax. And hepatic hydrothorax occurs in approximately 7% of patients with ascites. It's usually a large right effusion due to the increased formation of diaphragmatic rifts in the right hemidiaphragm versus the left, and so 80% are on the right. It can accumulate very rapidly, and what's important to realize is that 20% of hepatic hydrothorax can form without ascites, or the pleural fluid volume is way, quote unquote, out of proportion to any ascites volume. And remember that this is due to 2 factors: that many rifts in the diaphragm act as a one-way valve, so when fluid enters from the abdomen to the thorax, it doesn't return, and then negative intrapleural pressure generated by breathing effectively pumps the fluid out of the abdomen into the chest. So this finding of hepatic hydrothorax without ascites is not that surprising. We should remember that patients can develop spontaneous bacterial pleuritis, just like they can develop spontaneous bacterial peritonitis. And so effusions in the setting of altered mental status in patients with cirrhosis or signs and symptoms of infection or pleurisy should prompt a thoracentesis to rule out infection. If infection is found and it's uncomplicated, this is one pleural space infection that could be treated with antibiotics alone and without pleural drainage, very similar to treating spontaneous bacterial peritonitis. The difficulty in these cases is managing the accumulation and reaccumulation of fluid in hepatic hydrothorax. And I'll review some management techniques on the next slide, but remembering that a transjugular intrahepatic portosystemic shunt, or TIPS procedure, can be effective for refractory hepatic hydrothorax. Typical maneuvers to prevent reaccumulation of hepatic hydrothorax include standard diuretic therapy of spironolactone and furosemide for ascites and portal hypertension. In acute setting, IV albumin with diuretics can be used, and even medications like octreotide to decrease splanchnic blood flow can be achieved. All of these therapies were employed in our patient and failed, and ultimately a portosystemic shunt was placed via a transjugular approach, or TIPS, and he was discharged on a diuretic regimen with complete resolution of his hepatic hydrothorax by 3 months. One follow-up piece of literature that has come up regarding hepatic hydrothorax addresses the age-old statement to never place a chest tube in a hepatic hydrothorax because there's no clear endpoint. This often leads to excessive pleural drainage, leading to hypoalbuminemia, vascular volume depletion, and potential for even triggering hepatorenal syndrome and pleural infection, all significant, potentially fatal outcomes in patients with hepatic hydrothorax. However, in refractory cases like our patient, where TIPS is either not indicated, contraindicated, or could be technically challenging, there was a small pilot study published this past year in 2016 on using a tunnel pleural catheter, or indwelling pleural catheter, for these patients. And this study looked at 24 hepatic hydrothorax patients requiring at least one thoracentesis and placed tunnel catheters and were drained intermittently at sort of an as-needed schedule. And 33% of these patients had spontaneous pleurodesis after IPC placement, but the mean duration of pleurodesis was 130 days, quite long, and indwelling pleural catheter-related infections exceeded those used for other indications of IPCs, and up to 16%. But there were no infection-related deaths, and all infections seemed to be managed with either pleural drain removal or antibiotics, or both. So intrapleural catheter placement should be used with caution, but is a possible salvage option for hepatic hydrothorax in high-risk patients for other interventions, but also must be mindful of the high infection risk with this strategy. We're going to change gears slightly to discussing a pleural exudative effusion of unclear etiology. So this is a very common consult that we might see. This is a 46-year-old man with a history of myelodysplastic syndrome and has had an unrelated allogeneic stem cell transplant complicated by cutaneous and GI graft versus host disease. So clearly an immune-compromised host and not a normal host, but is presenting with dyspnea and progressive right-sided pleuritic chest pain for 3 weeks. He has no fevers, chills, or sick contacts or travel, and medications include potent immunosuppressive therapy with prednisone 20 milligrams daily, tacrolimus. He is on atovaquone and valganciclovir for prophylaxis. His chest X-ray reveals a moderate to large right-sided pleural effusion, as seen on both the PA and the lateral chest X-ray. He underwent a thoracentesis, and the serum LDH is 229, the fluid 226, total protein in the serum 6.5, the fluid 4.1, and the albumin was 3.7 and 2.7. So clearly an exudate by any criteria, but a bland exudate in that the pH was 7.6, the glucose was normal, and the amylase was negative, and the fluid adenosine deaminase level, or ADA, was 3.1, very low, pointing away from activated lymphocytes and tuberculosis. Cultures were sent for bacteria, AFB, fungal, anaerobic, actinomyces, nocardia, PCP. They were all entirely negative. Cytology and flow cytometry were negative for either solid or liquid tumor and malignancy. This problem, although the unique features of this host aside, is quite common, and pulmonologists see consults for exudative effusion of unclear etiology quite often. And in a frustrating manner, up to 20+% of all exudates have no clear etiology, even after extensive pleural fluid analysis from thoracentesis, as we did here, even after thoracoscopy and pleural biopsy. And many of these cases, when followed over time, even looking at autopsy series, are undiagnosed exudates from either occult malignancy, including mesothelioma, chronic empyema from atypical organisms, such as tuberculosis, unrecognized autoimmune or inflammatory diseases such as rheumatoid arthritis or lupus, post-pulmonary emboli effusions, or just simply organization from diuresed heart failure. So an algorithm at the most basic level to address exudates of unclear etiology includes the following. If the patients have a borderline exudate, really examine whether this could be a quote-unquote diuresed transudate, and look at other markers that might point you in that direction, such as the serum to pleural fluid albumin gradient. If it's greater than 1.2, that has higher specificity for a transudate than traditional Lights criteria, and that might point you in the right clinical context to this being a transudate. A pleural fluid BNP level that's very high could also point you in the direction of pulmonary venous hypertension and heart failure. And then in these instances, consider volume overload states such as CHF, nephrosis, or cirrhosis. In all other exudates, you really must take a very careful history, because identifying the etiology of any pleural effusion, especially exudates of unclear etiology, rests with the clinical and radiographic content and context, and must exhaust your history, microbiology, and cytology. If this is truly unrevealing, as in this case, always consider exudative or inflammatory effusion from PE and infarction and the appropriate studies for those, for that diagnosis. Consider tuberculosis, adenosine deaminase greater than 40 or pleural fluid interferon gamma level greater than 140 has very good negative predictive value and high sensitivity. And if this is negative, ultimately, a patient with recurrent or persistent unexplained pleural exudate should undergo thoracoscopy and pleural biopsy if there's no contraindication to this intervention. There are augmenting tests in the current era that can be done on pleural fluid or pleural cells to help focus our diagnostic evaluation. And these include relatively nonspecific markers, such as heart failure markers, as we discussed, inflammatory markers, more focused infectious markers, such as ADA, and malignancy markers of the older era, such as CEA and CA. And when cells are available, immunostaining has allowed for more potent and specific diagnoses of pleural metastases or lung cancer deposits in the pleural space with these advanced immunostaining techniques. And we are moving in an era of biomarkers for mesothelioma, including serum and pleural fibulin 3 and mesothelin, which are now increasingly available for detecting mesothelioma. So in this patient, pleuroscopy and pleural biopsy was obtained, and we see on the pathology and silver stain identifiable organisms, and on modified acid fast stain, no cardiosis was obtained, and this patient had pleural nocardiosis and was treated for a full course with antibiotics and did well. So in summary, we've reviewed empyema, hemothorax, thoracic endometriosis syndrome, chylous effusions, and hepatic hydrothorax in a case-based format, and reviewed an update on approach to the pleural exudate of unclear etiology. Thank you for your attention.